Welcome to the world of psychiatry. My name is Leonard Rappa, and I'm a board-certified psychiatric pharmacist and professor of psychiatric pharmacy practice at Florida A&M University, College of Pharmacy and Pharmaceutical Sciences, Institute of Public Health. I practice at the South Florida Pharmacy Practice Center and at Broward Health Imperial Point in Fort Lauderdale, Florida. Please pay close attention as I explain psychiatric terminology, legal information including medication and treatment consent, psychiatric-specific abbreviations, specific diagnostic criteria, personality disorders, and other relevant information to get you acclimated to the world of psychiatry. Thank you.
Before you begin your psychiatry rotation, there are certain things of which you must be aware. In the next few minutes, I'm going to review some of them for you. However, during your rotation, you'll be exposed to unique psychiatric terminology, abbreviations, diagnostic criteria, and laws surrounding a patient's rights while in the psychiatric hospital. This orientation is a mere introduction to this specialty. You must do a lot of the learning on your own through your own. Diagnoses are based on the DSM, or Diagnostic and Statistical Manual of Mental Disorders, which has evolved greatly over the last 60+ years. However, regardless of which DSM manual is used to diagnose a patient, there are specific factors which must be considered. Each diagnosis is like a recipe. It is a minimum number of symptoms which must be met and a time frame for those symptoms before any conclusion can be made. Up until 2013, diagnostic criteria in the DSM-4 TR, text revised, contained 5 different components or axes. It's important to know which is on each of these axes because many practitioners still use them today. On axis 1 is the main psychiatric diagnosis. On axis 2 are any personality disorders or intellectual disabilities. In a few minutes, I will be discussing axis 2 personality disorders more. On axis 3, there should be a list of concomitant medical disorders that contribute to the psychiatric illness, such as unstable diabetes, advanced HIV, or thyroid disorders. On axis 4, there should be a list of psychosocial stressors, such as loss of a job, bankruptcy, or even kids being bullied at school. Axis 4 should not have the words moderate severe. That's an improper diagnosis for this axis. Axis 5 contains the Global Assessment of Functioning, which is a number given on a scale from 0 to 100. At the very low end of the scale, people are functioning very poorly. At the top end of the scale, towards 100, people are functioning extremely well. Most hospitalized psychiatric patients will have a GAF score of less than 30. The DSM-5 TR no longer divides a diagnosis by axes, but instead consists of a singular comprehensive diagnosis. If a patient has more than one diagnosis, it should be listed in the order of priority for treatment. The DSM-5 TR now also matches the International Statistical Classification of Diseases and Related Health Problems, otherwise known as ICD-10, coding system. Where applicable, specific qualifiers for defining the disorder severity, such as mild, moderate, severe, or extreme, descriptive features, such as with good insight, in a controlled environment, and course of illness, such as in partial remission, in full remission, or recurrent, should be provided with each diagnosis. The ICD-10 codes for all mental, personality, and substance use disorders are under the letter F. As you'll see in the next 2 slides, the ICD-10 codes can be broken down into each individual discrete category. In the DSM-5 TR, for the most part, diagnostic criteria have not changed much for the major psychiatric illnesses, but some refinements have been made. The term NOS, or not otherwise specified, and NED, not elsewhere defined, have been removed. Mental retardation has a new name, intellectual disability or intellectual development disorder. Post-traumatic stress disorder and obsessive compulsive disorder are no longer part of the anxiety disorders. In addition, there is no longer a differentiation in the types of autism. The new diagnoses for any type of autism is autism spectrum disorder. There's even a new diagnosis called DMDD, disruptive mood dysregulation disorder, meant to capture children who have frequent temper tantrums and irritability. These children may otherwise be given the diagnosis of depression, bipolar disorder, or ADHD. Another topic of importance in psychiatry pertains to the law. In Florida, we have something called a Baker Act, named after the state representative from Miami, Maxine Baker. It is also known as the Florida Mental Health Act of 1971. The Baker Act is a law which protects a patient's rights while in a psychiatric hospital. Most other states have similar laws to the Florida Baker Act. A Baker Act form is a legal document which requires a person to be examined in a psychiatric hospital for up to 72 hours. A person who is in the hospital involuntarily would be under the Baker Act. An ex parte is a similar act to a Baker Act, except that it is issued by a judge in response to concerns over a loved one's mental health. It is usually started by family members going to court and asking a judge for the involuntary commitment of a person. Generally, the main criteria for who gets Baker Acted is if they are an immediate danger to themselves or others. On July 1, 2024, the Florida House passed House Bill 7021, which greatly expanded and simplified the Baker Act and Marchman Act laws. Some items of importance on the bill include expanding the authority of nurse practitioners and physician assistants, and allowing psychiatric nurses to abrogate a Baker Act. It also creates a more comprehensive and personalized discharge planning process and allows for the expansion of inpatient hospital beds. There are specific people who are allowed to fill out a Baker Act form. Police officers, psychologists, psychiatrists, emergency room doctors, and even mental health social workers can start a Baker Act. However, there are a limited number of people who can cancel, discharge, or abrogate a Baker Act if they deem the patient is not a danger to themselves or others. Only a psychiatrist or psychologist or psychiatric nurse practitioner can discharge a Baker Act. There's another way in which a patient can get into a psychiatric hospital for acute crisis stabilization. That is called a voluntary admission, and that is their consent for their treatment. The patient comes into the hospital or emergency room voluntarily and asks to be admitted to the hospital. A patient who is in the hospital voluntarily can request to be discharged at any time. However, they would fill out a form called an application for discharge, and it may take up to 24 hours of evaluation for the psychiatrist to either discharge the patient or to keep them for a longer period of time, under which they would initiate a new Baker Act. Remember, at any point, a voluntary patient can be Baker Acted while in the hospital and vice versa. An involuntary patient can also be made voluntary. When a patient's Baker Act is up in 72 hours, the physician must either discharge the patient or fill out another form to petition the court to keep the patient longer. The patient will be then put on the docket for the Baker Act court. If the court only meets once a week and the day just passed when the court was held, the patient may be retained for another week before they see a judge. In Baker Act court, the patient is given their own attorney, somewhat like a defense attorney. There is also a state's attorney, sort of like a prosecuting attorney, and the judge. At the conclusion of the patient's Baker Act hearing, the judge can decide to discharge the patient or retain the patient in the hospital for an indeterminate amount of time until the patient is better. It is ideal for the patient not to have to spend a long time in the hospital, so discharge is always the goal. As I mentioned before, a voluntary hospitalization by the patient is a consent for their treatment. While in the hospital, a patient is considered competent unless otherwise declared so. Competence is defined in the Florida Statutes 394.455, Section 15. Incompetence is determined in the hospital by the psychiatrist and later determined by the judge in court. A consent for treatment is different than a consent for medications. They are two different things. Even an involuntary Baker Acted patient may refuse medication if they are competent to do so. Competence to consent for medication basically means that the patient is able to understand many things about the medication, such as what it is, the indication, the dosage range, the risks, the common side effects, how it is monitored, and any alternatives that may exist for the medication. Even a psychotic patient may have the right to consent to their own medications if they can understand these things. A competent patient who is able to give their own informed consent for medications cannot be forced to take medications if they don't want them. To sum that up, patients can be in the hospital voluntarily or involuntarily and may be competent to consent to medications or not. Only the psychiatrist can make the determination of whether they are competent or not while in the psychiatric hospital. If a patient is declared incompetent by the psychiatrist to consent to medications, and medications are ordered for the patient, another person must consent for them. Before the court sees the patient, only a proxy can give consent for medications. A proxy is a family member or friend who knows the patient from before the hospitalization. When the patient goes to court, the judge will decide if they are competent to consent for their own medications or not. If the patient is considered not competent, the judge will appoint someone called a guardian advocate. A guardian advocate can be the same person as the person who was the proxy, or the guardian advocate can be an impartial third party that will give consent for the patient's medications. It cannot be an employee of the hospital because that would be a conflict of interest. It can, however, be a volunteer or even a student who may be knowledgeable about medications. If the patient has no family or friends and no proxy can be found before the court is held, then the patient may go unmedicated for the time being. The only exception to that is something called an emergency treatment order, or ETO. An ETO is given only if the patient becomes an immediate danger to themselves or another person. It is generally an intramuscular injection of an antipsychotic with or without an anticholinergic or benzodiazepine. We call this cocktail a B52 because the B52 name comes from the ingredients such as Benadryl, 5 milligrams of haloperidol, and 2 milligrams of lorazepam. Other intramuscular antipsychotics can also be used. In order for an ETO to be given, a physician must give a one-time order for the medication, which is not valid after 24 hours. Anyone, voluntary or involuntary, can be ordered an ETO if they lose control and become dangerous. Another law in the state of Florida is called a Marchman Act. A Marchman Act is for people with substance abuse problems and is similar to a Baker Act in that it is an involuntary hospitalization for up to 72 hours. Many times, parents will go to court called a Marchman Act court and ask a judge for a Marchman Act of their child or adolescent. Adults can be Marchman Acted as well, but their recovery from substance abuse is highly dependent upon their motivation. There is even a Marchman Act that can commit patients to an outpatient treatment, but it still takes the cooperation of the patient to participate in their own recovery. Psychiatric hospitalizations are usually short and used for crisis stabilization. If the patient is chronically ill or who has had many relapses of their mental illness, the doctor may petition the patient to go to the state hospital. The patient will then have to go to court again for the judge to make that decision. And if approved, the patient is placed on a waiting list for a bed at the South Florida State Hospital. Unfortunately, there are a limited number of beds at the state hospital, and some patients will remain in the acute care psychiatric hospital for weeks to months until they are placed in the state hospital. Other psychiatric topics of interest are the personality disorders. There are approximately 10 different personality disorders listed in the DSM-5 TR, which are the same as those listed in the DSM-4 TR. They have not changed. You can look into them further if you are interested. The reason why personality disorders are important is that it's estimated that at least 50% of hospitalized psychiatric patients have one or more of these disorders. It is important to note that medications are not effective on personality disorders. Medications may reduce some of the symptomatology, but medications cannot change a person's personality. The main treatment for personality disorders is really long-term psychotherapy. The hospital staff will sometimes use the term Axis 2 as a code to indicate the patient has one of these disorders. But knowing that medications are not effective does not mean that the patients are not prescribed them. Patients with personality disorders are sometimes prescribed a multitude of medications, which really don't work for the patient. When an Axis 2 patient is put on a medication and it doesn't work, another one is usually added. Then the process repeats itself until the patient is on multiple polypharmacy. I've nicknamed this the borderline cocktail. Hereafter, I will only review the two most common personality disorders, antisocial and borderline personality disorder. Having antisocial personality disorder is not the same as someone who is not socializing at a party or not being friendly. It was once called sociopathic personality disorder and occurs mostly in men, which is why you rarely hear of a female serial killer. Antisocial personality disorder is only able to be diagnosed in patients 18 years of age and older. However, the personality traits must begin much earlier. Before the age of 18, the child can be diagnosed with oppositional defiant disorder or conduct disorder, which are exactly as they sound. People with antisocial personality disorder display a pervasive pattern of disregard in violation of the rights of others since their teen years. There also has to be some evidence of conduct disorder or oppositional defiant disorder before the age of 15. The personality disorder is excluded if the patient is in the course of psychosis from schizophrenia or mania from bipolar disorder. It is believed that this disorder comes about because people have less of a fear response to dangerous stimuli, and so they're less afraid of consequences of their action. Hence, they rarely plan ahead and make impulsive decisions. The criteria for antisocial personality disorder also includes performing illegal acts, being deceitful and lying, or conning others. They can be irritable and aggressive. They can show reckless disregard for the safety of self and others. They may be consistently irresponsible with work and financial obligations. More importantly, they may lack remorse and be indifferent to or rationalizing having hurt, mistreated, or stolen from others. Many people with this disorder end up in jail or prison, or even Congress. Well, all joking aside, if the person is provided with a good moral foundation during their formative years, they may end up being a fireman or a policeman, where having less fear is. Borderline personality disorder occurs mostly in women. It is believed that early childhood trauma and parental neglect play a large role in the development of this disorder. People with borderline personality may feel a chronic emotional pain or emptiness inside. To cope, many of these people self-mutilate, such as cutting on their arms and legs, where they feel a sense of relief when doing so. They often have an unstable self-image or sense of self. They usually have patterns of unstable and intense interpersonal relationships, characterized by alternating between extremes of idealization and devaluation. For example, one day you may be their favorite person in the whole world, whereas the next day you're their worst enemy. Borderline patients make a frantic effort to avoid real or even imagined abandonment and may show impulsivity in at least two areas that are potentially self-damaging, such as spending, sex, substance abuse, reckless driving, or binge eating. They can have recurrent suicidal behaviors, gestures, or threats, and have a highly labile mood. They can sometimes have paranoia and dissociative symptoms, and like antisocial personality, display inappropriate, intense anger, or have difficulty controlling their anger, such as in having frequent displays of temper, constant anger, or recurrent physical fights. Several movies have been made with the main character that has borderline personality, such as Fatal Attraction, Swim Fan, 13, How to Lose a Guy in 10 Days, and My Super Ex-Girlfriend. I hope this review has given you the basic understanding you need to enter the world of psychiatry. If you have any questions, feel free to email me at rxpsych@yahoo.com or leonard.rappa@famu.edu. Thank you very much.